next, I'd like to go ahead and turn it over to Dr. Geoffrey Eubank. He's going to give us an exciting update on progressive MS.
Thanks, Jackie. Yeah, I'm happy to be here today. I don't know why I put soup on there. It just said Progresso, which reminded me of progressives, so there's nothing more to it than that. So with that goofy little soup can to begin with, we'll move forward. So many of you, I'm sure, when you heard about MS, we talked about the different types of MS. We talk about, the four that are up there, the relapsing remitting, which is the most common, and then secondary progressive and primary progressive, and this rare thing called progressive relapsing. And we've actually started to talk about this a little bit differently and how we understand things, but it's not a terrible place to start because I think it does represent that each person with MS, not only are the various symptoms different from person to person, but exactly how they're presenting themselves over time is different. So we're mostly going to talk about progressive MS today, but before we can talk about progressive MS, we have to talk about what we're not talking about. And so when we talk about relapsing MS, we're talking about an attack. And if you're people in the audience today, I would ask anybody if they knew what this movie scene was from. It's one of my favorite movies. I actually had my 8-year-old watch this. That was a mistake. I was trying to show him all the classic movies that I liked. But if you didn't know, this is a scene from Braveheart. And so that is an attack. And when we're talking about what is an MS attack, what we're talking about are either brand new neurologic symptoms or a substantial worsening of current neurologic symptoms. So that could be anything from vision loss, it could be weakness, it could be numbness, it could be balance difficulties, etc. And we kind of have some definitions so we make sure that what we're calling a relapse is a relapse and we're not mistaking it for something else. So one of the things we do is we require these symptoms to last longer than 24 hours for us to call them a relapse. That doesn't mean it's absolutely impossible for a relapse to be shorter than that, but if we start calling things that are just there for a few minutes, we're probably not calling the right thing a relapse. And also, if somebody has an attack today and a week or two later they have some new symptoms, we're generally going to regard that as part of the same relapse. The other thing we want to do is exclude what we're calling a pseudo-relapse. So if I get a call from one of my patients and they say, hey, my right leg's weak, and it's been that way for 2 or 3 days, we're always going to ask, what else is going on? Are you sick? And maybe they just had a flu 2 days ago, and I might tell them, you know what, it's probably because you have an infection going on, maybe you have a fever, and that will either bring out old symptoms or amplify your current symptoms. Sometimes you don't even know you have an infection. Urinary tract infections are a little bit notorious for being able to do this, and so we'll oftentimes just check a urinalysis just to be sure that that's not what's triggering things. Typically when we have an attack, we oftentimes will, if we do an MRI scan, we might see a new spot on the brain, and we actually may see what we call axial enhancement, which we think typically represents inflammation. So that's what we're talking about when we're talking about an attack. Now, I just told you what we're not going to be talking about today, but that's just to kind of separate it from the other aspect of MS, which is, what is this progressive MS? It's also super important, and it's actually one of the hardest things for us to treat sometimes, it feels like. And what is it generally? The easiest thing to say is it's worsening of neurologic dysfunction that's occurring independent of these relapses we talk about. So if you have a relapse and you get worse, that's worse because you just had new inflammation and damage. But sometimes you're gradually getting worse month after month, year after year, and that's what we're more speaking of here. For us to call something progressive MS, some of the things we're looking for is some objective supporting measures. So somebody may tell us, hey, I'm feeling worse. And how do we evaluate that? Well, we're going to do your neurologic exam and see if a muscle is weaker than another muscle. But then we're also going to do some specific measures. We have some fairly classic things that we do both in research trials but also in our offices. We might see how fast you walk 25 feet and see if you're slowing down over time. We also do some tests to check hand coordination and function, and that's with our 9-hole peg test. Cognitive changes, a little bit challenging to do in the office, but we do have a couple of options that we do there. Something called the symbol digit modality test is the one most commonly going to be used in the office. We look at MRIs, but the MRIs oftentimes are going to be different in someone with progressive MS than not. Sometimes we'll see lesions getting a little bit bigger over time, and then we'll see some other things that are subtle and sometimes harder to measure directly from scan to scan, but sometimes we'll see a little bit of shrinkage of the brain. A picture of the optic nerve, we can measure how thick the optic nerve head is, the retinal nerve fiber layer, and if that's getting thinner, that's kind of a marker for progression as well. And then the last one there says labs. It would be great if we had a blood test that would tell us, hey, if we test this and it's elevated, that shows that you're progressing. One of the hotter lab tests that we're thinking about now that may be helpful for us is neurofilament light chains. As it turns out, that's not a very good test to tell us if someone is in progressive MS or not. It's useful in other scenarios and it might predict future progression, but it's not super helpful right now to say, hey, I can do this blood test to see if your MS is progressing or not. So we've got two broad types of progressive MS. I'm going to separate them out here, although they're probably quite a similar thing going on between the two. We have primary progressive MS, and this is a type of MS where the person typically does not have relapses. They just gradually accumulate worsening problems, or they accrue new problems, but they never actually get better. If they get better, it's just marginally better. And they never get worse in a hurry. It's just this slow, gradual worsening. An example might be one day somebody says, hey, you know, I walk and after about a mile or two, my foot starts to drag just a little bit. But then you talk to them 2 years later, and then every day they wake up and they have a little bit of a limp. And then over time, more and more develops. So that's kind of a classic story. For us to uniquely define somebody as having progressive MS, we're usually looking for at least a 1-year history of worsening neurologic function. So we kind of almost have to say, I think this is what you have, and sometimes we have to just watch and see what happens to be particularly certain of that. In addition to that story and the exam that we do, we're also looking for additional confirmatory factors. The testing that we do is certainly similar to what we would do with all other MS patients. We're looking not only for brain lesions typical of MS, but with primary progressive MS, we're also looking for some of these other factors. So oftentimes we're looking for spinal cord lesions, and then oftentimes we'll want abnormal spinal fluid. So you have to have at least 2 of those 3 things there in addition to the proper history and exam for us to make that diagnosis. Secondary progressive MS is somewhat similar. These people initially show up with the relapsing form of MS, but after they've had it for a number of years, they can develop this gradual progression. And that gradual worsening that occurs, first of all, we try to define it by it going on for at least 6 months. So sometimes people get worse for a month or 2 and then get better. That may just be a relapse. But if they continue to gradually get worse for at least 6 months, and that's not due to relapses, we start to consider that secondary progressive MS. Now you'll see a little star there and it says, except when you're having relapses. So you can actually have this progression and on top of that still be having relapses. So you can tell how it can get a little bit complicated to sift out there. So how are we defining that? It may be that our patient or you are telling us, hey, maybe my walking is getting worse, or hey, I was doing good at work, but I'm really struggling with multitasking and remembering how to do things. So we're listening to your story about whether things are worsening. Other times, we might see a worsening on the examination, and sometimes it's one or the other or both. So the patient may think they're doing fine, but we notice, hey, they're definitely slowing down in their walking, or other aspects are getting worse. And then we'll do an MRI scan, and when we're dealing with progressive MS, and if the primary issue is progressing, we actually won't typically see new lesions on the MRI, or we won't see the enhancement. Most of the time it looks stable, although sometimes you'll see some of the spots have gotten a little bit larger. And you can tell we have to sift out a lot of things here. And even though we say, hey, we can make this diagnosis if you've been getting worse for about 6 months, oftentimes there's a bit of uncertainty. And one study showed that sometimes it can take roughly 3 years for the average person having progressive MS until the person is called progressive MS. So first of all, we want to be sure of what we're dealing with. But second of all, some of these differences can be fairly subtle as well. So how are relapsing and progressive MS different in the first place? This is just an overview, but with relapsing MS, we typically are thinking there's really unique places in the brain or the spinal cord that are being impacted. That's the inflammation that occurs. And with that, people have very specific relapse symptoms that we're used to identifying. And as I've already alluded to, the MRI will oftentimes show these new lesions. With progressive MS, we aren't seeing that focal inflammation anymore, but we still think there's inflammation going on, but it almost goes from being in a particular spot to almost being more widespread. And when we look at where this inflammation is by various studies, we oftentimes see it's kind of diffusely over the surface of the brain or just underneath the surface of the brain. And we think that's probably what's driving things. So it's a different kind of inflammation, probably dealing with different cells as well. And again, we see this gradual worsening, and I've already pointed out how the MRI is different. One of the things that I'll point out there that I didn't point out earlier is that we can see this thing called atrophy, which is just a fancy word that means shrinking. And what the surface of the brain, what we call the gray matter, can gradually shrink. And then there's in the deeper parts of the brain, there's a part called the thalamus that also can get smaller. And when those parts are shrinking, it correlates with people having progressive MS. So I've got a couple minutes here, and I'm going to skip through this super busy slide, but that's a way of saying that there's a lot of things going on here. We still have what we call active inflammation, but we also have what we call neurodegenerative disease, and that means parts of the brain that have been injured have a certain lifespan, and they might be dying off quicker. So it's real short. I'm not going to have time to go through all of that. And then we also have, the rest of us, how well our health was before this occurs. And if we have other health factors that are gradually getting worse, that's going to go ahead and contribute to some of that decline. So there's a lot of different things going on there, not just one thing. So I wanted to finish the last couple minutes about how we're treating progressive MS. Here are some things that didn't work for MS. Some of our drugs that work for relapsing MS have been tried, and all of them listed there were demonstrated not to be helpful. There's a caveat there. There's a drug called Rituxan there that didn't really work, but if you subdivided parts of that study, it looked like it might have worked. But they've looked for secondary progressive MS with some of our treatments. There was excitement about a vitamin called biotin that turned out not to be effective, unfortunately. So for the first time, we had a drug that was found to be effective for primary progressive MS. It was a drug called ocrelizumab or Ocrevus that you've likely heard of. And the people that took that as compared to placebo patients were 24% less likely to develop confirmed disability. And it also seemed like the people that had their walking slow down, that wasn't occurring as often in people on ocrelizumab. So it was pretty exciting. And one of the things in that trial was that they did have some younger patients in there, patients with inflammation, which is what we learned with rituximab. It actually demonstrated that if you look at the right patients, you may be able to see that benefit. Other drugs that have been shown to be effective for secondary progressive MS, there's a drug that we don't use very often now called Novantrone. The reason we don't use it is you can't use it for very long because of cardiac injury, and it can produce malignancies like cancer or like leukemia more commonly. And then we also had a drug called Siponimod or Mayzent, and it was used, and it showed a 20% or 21% reduction in that disability progression. Now, the people that were in that secondary progressive trial were still having active relapses. So what happened was it got approved for what we call active secondary progressive MS, which means these drugs do work in patients that are still having relapses but that are progressing. And then I'm just going to briefly touch on these. There's some excitement out there that we have some other drugs that look like they could be useful for progressive MS. There's a drug that I'm not going to pronounce right called masitinib, and it works on tyrosine kinase. And the initial trials showed that it had a reduction in a 37% reduction in disability progression, and they're now doing larger phase 3 trials, both for primary progressive MS and secondary progressive MS. There's another exciting class of medications called BTK inhibitors that look like they could be useful for progressive MS, so they're being studied both in primary progressive and secondary progressive MS. You'll see that in both columns. And then lastly, there's a drug called Abudilast, which is another immunomodulatory drug, and it showed some positive results on imaging with MRI and OCT, and now it's having a phase 3 trial looking at people that don't have active secondary progressive MS, but those still having relapses. So even though we're not there yet, it doesn't seem like a pipe dream that we may have treatments that are going to be effective there. And I'm going to skip through that for a second. What else do we need? We need things that put the myelin back on the nerves. We've looked for those. We don't have them yet. We need things to regrow nerves. We don't have those yet. We need things that protect the nerves to begin with so these things don't develop. Those are things that are on our list of wants that we don't currently have. I'm not going to spend any time on this because the quality of life intervention things that Dr. Wu talked about and that our next speaker are going to talk about, it's like just because we don't have a drug for something right now doesn't mean we don't have a whole lot of other things that we can provide to our patients having progressive MS to not only slow things down, but actually improve their quality of life and improve their functioning. So with that, I'll take a break.
All right, well, thanks so much, Dr. Eubank. We really appreciate that excellent overview of progressive types of MS and the treatments that have not benefited folks with progressive MS, as well as the treatments which benefit. And it's such a great segue into our next presentation because that quality of life and holistic approach to MS care is incredibly important.